Hello everyone, this is Chadi Alraies from CVI 2024. I'm really privileged to be with my friend Yader Sandoval to talk about a very unique technique. It's called CT to PCI to plan a successful PCI. Yader, thanks for being with us.
There's a lot of data for intravascular imaging, right? For OCT, for IBIS, and we know that imaging improves outcomes and how we can use that to better characterize morphology and lesion length and whether there's calcium or not. And we know this from intravascular imaging. And what we've learned now for some time, and we're increasingly learning of many opportunities, is that can we just use CT to better plan our procedures for pre-procedural planning and even help for intra-procedural decision making, right? So this is pretty much what CT-guided PCI is. This was a concept that I would say some years ago was not feasible for numerous factors, maybe software, hardware, algorithmic approaches. There were a number of, I would say, technical barriers and also education and data. But at this particular point, in 2024, it's clear that it's just the right time that the technology, data, and software and hardware now allow this concept of CT-guided PCI to be possible.
So is it just a CT coronary that helps you guide, or something specific? And
so it's pretty much the CT, and I would submit that it's mostly a change in the mindset. That information has always been there.
Yeah.
But us as interventional cardiologists, we have not historically looked at the data.
And
the information has always been there. But now I think that we know what we are looking for, and we have better algorithmic approaches to look for that. Now we have incorporated that into our practice. So what is CT-guided PCI? Again, as I said, it's a shift in thinking about the test as just being a diagnostic test to say you have severe CAD or not, which is how historically it has been looked at to triage patients that need to go to the lab or not to the lab. But think of it now as a therapeutic sort of approach. So what we've done is that, in our practice, we use a lot of CT to evaluate patients with suspected coronary artery disease, whether it's acute or chronic coronary syndromes, largely, of course, chronic coronary syndromes. But there are patients that come to the hospital with some obscure unstable angina sort of situation or something, or increased troponin that sometimes get CTs. And if they are being considered to come to the cath lab, then we look at that CT in a very algorithmic fashion. So what do? We look at the CT, and I would say, as I said, very analogous to IBIS and OCT. We're looking at the morphology, at the length. We're trying to understand lumen estimates, and we're looking at this in a very strategic fashion. With the basic CT software interpretation, again, you can get a lot of information about morphology and anatomy. So you can understand what guide do you need, because you can say, oh, the aorta is a little bit dilated, so maybe I need an XB4 rather than an XB3.5. Similarly, you can say, oh, the RCA's come in anterior, so I don't need to fumble and use more radiation and contrast. Pass me an AL1, it's anterior. So just for basic things as what guide and catheters you need is very helpful. And when you add these steps of CT-guided PCI little by little, this helps. It is expected to likely help improve your workflow and reduce contrast or radiation.
And also target the lesion of interest and get out.
Absolutely. So of course you go with the CT, and we're interventionalists, we're not the readers, but the readers are already telling you, hey, there's a problem in the LAD, right? So therefore, us interventionalists can now, I think our job is to now say, all right, let's just not think about this, let's say an LAD lesion from a diagnostic perspective of being severe, but let's look at that CT. All right, what guide size do I need? Is it a bifurcation? Maybe it's a bifurcation, maybe I should go up with a larger size, like a 7 French up front. Let's look at it. Is it calcific? If it's calcific, maybe I should be thinking more upfront about calcium modification strategies. If it's bifurcation, maybe I need 2 wires. So you can see how all this information is in the CT, and if one just strategizes how you're going to look at that, it really changes your approach. In our practice, it has been incredibly valuable and supported by our practice, because this is similar to all the US. There's a lot of heterogeneity in the cath labs now, right? There's non-surgical backup labs, there are ASCs, there's your motherships that have all the toys and gadgets to treat complex lesions. So CT is a great triaging tool, because if the CT tells you, hey, this is a subtotal or total calcific lesion, then you say, I want this at 8 a.m. with Manos Relaxis, right? Yeah. So you can use this to very triage this to, I like to call it the what, where, when, and who. So you can use CT to say, who should do this, which hospital should do it, what equipment is anticipated that you need, and you can really, again, really strategize.
And you can tell the staff what equipment you need before
Absolutely.
the laundry list of stuff. So you're
Absolutely. The other day we were doing some cases and teaching the approach to some folks that came to our lab to learn about this. They were very impressed in how before even getting started, we were trying to set up the case, how we pretty much approach our team, our techs, and we said like, hey, we need 7 French sheath. This is we need 2 wires for the bifurcation. We pretty much told them everything we were anticipating, and that's very, very, very helpful. So for clinical practice, I would say that, and that you could make the case and argue this is what we're doing in our practice, is that there's a lot of tools that are clinical for prime time to assess anatomy, morphology. Physiology is a big aspect of that. So something that how we actually started the journey of CT-guided PCI was because, FFRCT has it's often thought as a diagnostic test, right? That you say, oh, if the FFRCT is above 0.8, you don't need to go to the lab, and it's sort of like the gatekeeper, right? Because you don't have significant functional disease. We've taken the other totally different approach of saying, like, if the FFRCT is abnormal and it's a significant functional lesion, now we have access in our practice to what's called an FFRCT-based virtual PCI planning. So in all these cases, particularly those that we are able to incorporate FFRCT, we can also do virtual PCI planning. So what we do in these cases is that pretty much from the CT, we have 3D models. The 3D models allows us to see where is the lesion, and you can literally implant a virtual stent, and you can choose the length based on what your predicted post-PCI FFRCT. This has actually been validated by a group in Belgium that validated this against pressure wires, and it works really good. So we've been doing this now in practice for over a year. It's an FDA cleared tool, so again, you can, as you can see, sometimes at meetings, as you know, we like to think about morphology or physiology, or but with CT, the beauty of it is that pre-procedurally, you can really have a comprehensive approach that allows you to assess the morphology and anatomy and the physiology. Right. And that's what we've been doing in the practice. So again, we can choose your guide, choose your equipment, choose your wires. Calcium is a big part of this equation because that helps you with case complexity and physiology, both pre and post-procedural planning for stent planning. So this is everything that we're doing.
And as you started already a conference before, but there is a conference coming up for people to sign up related to to learn this technique.
Yep, absolutely. So we have efforts, I would say, on three major aspects. One is, of course, clinically, we're doing this and learning more about it every day. From a research perspective, there's an ongoing major multi-center trial called the P4 trial. It's randomizing patients with abnormal CT and abnormal FFRCT to IVUS, or a CT-guided PCI approach. It's being led by a group in Belgium, and there are a few sites in the US that will likely start soon. So there's actually a lot of efforts to generate more robust evidence-based data perspective randomized studies. And from an education perspective, there's a lot of opportunities for us as interventional cardiologists. The imagers have seen this every day, but for us as interventional cardiologists to understand the value of that. We did the first meeting, the first CT-guided PCI course in Minneapolis back in March, and we're doing the next course in October 24th, 25th. So anybody that's interested in this, it's a 1.5 day of what will be lectures, hands-on to play with all the different softwares to how to do this, and we'll have a couple of live cases to illustrate the concept.
Absolutely. Well, for everybody listening, we're going to put the link for you in the description for the signing up for the course. Thank you everyone for watching us. This is Chadi Alraies from CVI 2024 in Denver, Colorado.